Good afternoon, and welcome to Getting Your Arms Around Enterprise Content Management, a complimentary webinar from healthsystemCIO.com, sponsored by OnBase by Hyland. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemCIO.com, and I'll be your moderator today. We encourage questions, and I would ask that you type them in at any time into the Q&A box in the lower right-hand corner of your screen. We'll leave the default set to all panelists. Go ahead and send them in at any time and as they occur to you, and I'll be looking at those and prioritizing them and posing them to our speaker later in the program. You can download the deck. I've sent the URL out in your chat box. You see it on your screen. There's also a shortened URL at the bottom of all slides. And we are recording today's event, and so there will be an archive, usually ready within 2 business days. You will receive an email when it is ready, and a separate registration is required. So you can see how we're going to spend our time today. We're going to go about 45 minutes. First, we're going to hear from Dr. Mitchel Krieger, Associate CIO at the Cleveland Clinic. Then we're going to hear from our sponsor, represented by Susan DeCathlano, VP of Healthcare Sales and Services with OnBase by Hyland. And then we're going to do our Q&A with Mitch. So without further delay, I want to turn it over to Mitch Krieger. Mitch, thanks for joining us.
Thanks, Anthony. Okay. Very good. So I was asked to talk a little bit about enterprise content management, and certainly that's a very broad topic that involves both clinical as well as administrative activities with any healthcare organization. But I think as a physician, you know, my focus and my bias tends to be toward things centered around clinical activities. So I thought I'd talk a little bit about how ECM is important and impacts clinical workflows and the day-to-day activities of our caregivers. So, you know, as a general agenda, what I thought I'd do is start with a little bit of background about the Cleveland Clinic, and I think it's important because it really highlights some of the challenges of implementing these sorts of systems and processes across a large system. We'll talk a little bit about some of the strategies around managing clinical content and with an ECM system, and how we optimize the delivery of that content to the clinician to make them more efficient. And then finally, kind of where we really want to go in the future with this in order to make the process work better and to enable our caregivers to be more effective. So to give you some background, you know, Cleveland Clinic is a fairly large health system. We have roughly 44,000 caregivers. We have close to 5,000 beds system-wide distributed across a number of hospitals with nearly 3,000 physicians and scientists and a large graduate medical education program. So lots of people touching the patient's record and adding and modifying the record. If we look at kind of how things are distributed in the greater Cleveland area, we have our main campus hospital, which is roughly 1,300 beds, and then 9 other community hospitals in the region, giving us our footprint in Northeast Ohio. Importantly, though, we also have some nationwide as well as international presence with facilities in Toronto, Las Vegas, and Palm Beach, Florida, and then we have a new hospital coming online next year in Abu Dhabi. So the reason this is important is that, you know, we use a single electronic health record platform within our healthcare system, and information and data about patients from all these facilities is gathered in a single database. So you can imagine this would become quite unwieldy if you didn't have a way of managing that information and a way of distributing it to the caregivers. So the My Practice record is really our core platform, and it's based on the Epic clinical record, and all caregivers across the enterprise use this single system. To give you an idea of the sort of the breadth of information and data and usage of the system, we have more than 50,000 users using it on any given day, and sometime mid-morning, right around 11 o'clock, you'll have roughly 30,000 users hitting enter at the same time. So there's a huge volume of information going within the record. We have close to 7 million patients now in the record, and we continue to add information, both structured as well as unstructured. So if we look at the data that's in the clinical record, really only 20% or so of the information is in structured format, and the other 80% being unstructured. And it's acquired either through images, through transcriptions, through scanning, through a whole variety of methods. So the challenge is really, how do we acquire the information? How do we store the information? How do you access the information? And then finally, how do you display the information in an efficient and intelligent fashion that enables the caregiver to do their job? So this is something that many of you may have seen through other presentations, but really what these three rings represent is kind of the three sort of systems that manage content within the healthcare enterprise, and the intersection of this is what we call the enterprise patient view. So it's the place that we're able to see data within the electronic health record, information related to DICOM medical images, and then other non-structured information contained in traditional ECM systems. Our goal is really to deliver this information through a single access point. So for the clinician, that's the EMR system. On the administrative side, it may be a different system, but we're going to focus on the clinician side. So we want to deliver ultimately the right kind of information within their normal workflow. And I think as a general principle, and this is something that we follow at the clinic when we design systems and design the use of systems, is that we want to maximize user acceptance and acceptance of these efforts by allowing the user to access information within their normal workflow. If we create a workflow that forces them to leave the usual tools that they use day to day and go to, say, separate viewers or separate programs, then they're not going to use the system as effectively, and it's going to cause problems. So what we want to do is to have them operate within that single access point and have access to all the relevant information, hopefully delivered in some sort of context. So let's sort of start with the circle around images. And historically, our view of images is very fragmented. We acquire images through a variety of means. They may be traditional radiology images, they may be ultrasound, endoscopy images, light images through dermatology, and things like fundoscopic images obtained through specialty devices and specialty cameras. And what we've tried to do at the clinic is avoid the issues that we traditionally see with access to these images, where they're perhaps stored at the point of acquisition but not readily distributed to all users. So all these images are now taken and saved in a common clinical image library that allows those images to be indexed, viewed through a common viewer, and then we provide some sort of a common storage mechanism. This is then merged with our EPIC clinical record and essentially allows us to deliver the images within the electronic health record through a single viewer. More importantly, what this allows us to do is to deliver multiple images and provide really a longitudinal view of the patient's record or the patient's care. So in this case, we're able to deliver a arthroscopic image of a knee procedure, as well as the accompanying MRI scan, to allow the clinician to compare within the tool set that he normally uses side-by-side images. And this becomes a very powerful tool for the clinician and really enables them to make better decisions, hopefully, and get better information from the data that's available. These kind of images are also distributed through mobile devices, so it's not just through a normal terminal that the clinician can access these images, but also through these other types of devices. So if we go back to our rings, so we talked a little bit about medical images, and what I want to talk a little bit about now is more traditional enterprise contact management software. And this is really the software that allows us to manage all the unstructured information that comes in from scanned images or non-DICOM types of images. And this presents a huge challenge because, number one, it's coming from multiple sources, and number two, how do we assign these images in a way that it's easily accessible and we know where to get the information that we want. So in our own institution, we've really tried to identify the types of images that are acquired and to determine and to set up a standardized process for this image acquisition. So whether it's a front desk and they're acquiring images of maybe a patient's driver's license or insurance card, or if it's reports that are being scanned in, all users follow the same general process and attach appropriate metadata to the image at the point of acquisition so that it can be properly stored and filed. This has been an ongoing effort over the last 6 or 7 years, and we've gradually increased the scope of these activities from small pilots initially to really an enterprise-wide effort to a point now where we have more than 200 files stored, and we continue to archive additional documents at a rate of about 700,000 documents per week. So there's a lot of data there, and obviously if you don't have a good way to track all that and know where things are, it can get quite unwieldy very quickly. So within the clinical side, within the electronic health record, we've designated more than 160 types of document types that tie to the metadata and to the information that's stored around the acquisition of the image. We have more than 30 interfaces with other systems where these images are being acquired, and we've integrated with a number of types of devices to allow us to scan documents, scan reports, retrieve them, and also obtain e-signatures from patients on specific images, and then bring that into our EPIC clinical record and file them in a way that it's readily accessible and identifiable by the clinician. So if we look at some of the other clinical systems that are integrated, this is just a partial list, but really, you know, we look at the EHR, in our case EPIC, as this, you know, core system, but it doesn't exist in isolation, and certainly there are literally dozens of other systems that it integrates with and interfaces with, and these are all sources of content that the EPIC clinical record needs to be able to display in a meaningful way. So the challenge is, you know, now that we have all this information, so we have document images, we have medical images, and we have all this structured data that's actually been entered directly into the EHR, is how do we deliver this to the point of care in a context-specific way? You know, if you think about the days before we had EHRs, you would have a patient record, and you know, essentially what your job was to do as a clinician was to sort of flip through the chart and to find what you needed. And then, you know, the first iteration of EHRs is essentially now we have a electronic version of that record, and you know, we're clicking through the chart trying to find what we need. And unfortunately, in a system where you don't have good identification of these scanned documents and these non-structured information, very often it's difficult or if not impossible to find what you need, and that leads to a great deal of frustration on the part of the clinician to try and find perhaps the latest report or the latest insurance card or whatever the most current information. So, you know, the question is, how do we use the I don't want to say intelligence, but the logic that can be built into a a computerized system to go into the system, pull the information that's relevant for the specific situation that we're looking at. So maybe care of a patient with a particular disease process or care of a patient on a given day, and deliver what is needed, when it's needed, and where it's needed. And that's really the challenge. So our goal, as I said, is create a single content touch point so that in one place the clinician can get a longitudinal view of whatever relevant information there is that's relevant to the specific situation that they're dealing with. And if we can do that, it really transforms the experience of the caregiver, because now it's a tool for them and no longer a burden to click through the EHR and try and find things. So you're going to get better adoption, you're going to get better satisfaction, and ultimately it improves the overall process and creates great efficiencies in their own workflow. Physicians, as they use EHRs, become very jaded, even if an EHR is well designed, that they may have to do 5 clicks to get to a certain point, and why do they have to do 5 clicks when they could do 3 clicks? Well, if we can now deliver the information that they need with a single click or to a single point, then that really improves their satisfaction and improves their ability to do their job. So this is a kind of a view of not really where we are right now, but I think where we want to be. And the idea here is that we are able to provide information in context that's relevant to the specific thing being looked at. So in this case, it may be a patient that has specific disease processes noted on their problem list, and that problem list will drive some of these tabs, so that if a patient, for instance, has congestive heart failure, all the relevant information that a clinician might want in order to assess the patient for that disease process is going to be drawn into a single location, and then that allows the physician to then click through each of these documents and look at them and try and use the information to render an opinion or to render treatment. This is opposed to the traditional view where they're clicking through different tabs within the EHR and trying to find the most recent studies or the most recent information. So why not use the sort of the smarts of the computerized record to draw that information to a single place and try and deliver it so that it's context specific and relevant to the situation. On another view, perhaps we can allow clinicians to create their own parameters. So, we might go through and create sort of default tabs so that for, say, in cardiology, these are the specific, this is the specific information that's likely to be needed. But as each provider is an individual, and a specific provider may decide, no, these are the things that I want. We'll let them build their own template so that when they go to a patient's chart, the things that are relevant to them, for them, and important for them are brought together. And it's going to bring the latest versions of these various types of films. There may be 3 or 4 different EKGs in a patient's record, but it may be important for just a single most recent EKG to be brought in, or maybe a series of EKGs so they can see progression over a period of time. Allow the physician to help develop some of that logic and apply it to the patient's record. And if you're able to do that, it makes the clinician much more efficient and ultimately much more effective. And the only way you can do this is really to have a good process for acquisition of the information, and then really applying the right metadata to these images so that they can be identified and pulled in. So I think, to sort of wrap things up, the future of all this is that you really want to enhance this process for image acquisition. And I think one of the places right now where there's a sort of a shortfall, and this is, I think, for pretty much everyone, is we're getting more and more data or documents that are coming to us not in traditional paper format, but through electronic means. So how do we manage this information that's coming through some sort of health information exchange and be able to integrate it into the record the same way that we integrate more traditional documents that are acquired through scanning or other types of methods. In most cases right now, a lot of the information that is brought in through these information exchanges is brought into the record, but is often segregated in a separate portion of the record, and it's not part of the normal workflow of a clinician to go to that portion of the record. So how do we bring that and bring it so that it's front and center and relevant for the clinician? The next challenge is really as we archive these images, we have to do it with the appropriate metadata so that we can really identify and make them searchable and locatable. Ultimately, this will lead to our ability to actually extract some structured information from these unstructured documents, and that will make it even more relevant. But I think ultimately the goal is the challenge is to deliver what is needed by a clinician, where it's needed, and when it's needed. And if we could do that, we're really doing a service for our caregivers and for our clinicians. If all we're doing is creating a system that's archiving tremendous amounts of data, but it's not presenting it in a way that is functional for the clinician, then we're really doing a disservice to our caregivers and not benefiting our patients. So with that, I think I'll end and transfer things back over to Anthony.
Well, very good. Thank you, Mitch. That was a great presentation, and we look forward to Q&A. So just want to remind everyone to go ahead and send your questions in at any time, and we'll take a look at those. Okay, so at this point, we're going to hear from our sponsor, OnBase by Hyland, represented by Susan DeCathano, VP of Healthcare Sales and Solutions. Susan?
Thank you, Anthony, and thank you, Dr. Mitch Krieger, for a wonderful presentation. Hyland Software and Cleveland Clinic have been long-term partners, and we've appreciated the opportunity to work with Cleveland Clinic on implementing OnBase at their organization. Dr. Krieger provides a great overview of how an OnBase enterprise content management solution can address an organization's electronic health record strategy, as well as to be able to expand the access to clinical content for their clinicians. As we address our enterprise content management solutions within a healthcare organization, certainly we are available to complement and expand access to patient information as part of the organization's clinical strategy, as well as be able to address workflow across an organization, such as in human resources, accounts payable, and throughout the patient life cycle, starting at the patient registration through Health Information Management Department and Patient Financial Services. So certainly the overview that Dr. Krieger provided highlighted specifically around the electronic health record strategy at Cleveland Clinic, but OnBase expands beyond to other departments across an organization, being able to address departmental requirements. As part of that enterprise solution, really being able to not only capture content, both from a paper to electronic transition, as well as being able to capture digital photos, EKG results, medical images, but be able to incorporate that in a workflow process that provides access to end users, being able to make decisions on routing different types of information and taking action on that, as well as being able to store and manage that information. And a key point to what was discussed in today's webinar is really the ability to integrate OnBase to an electronic medical record, as well as to other line of business applications such as a ERP. And we have just recently released our OnBase version 14 of our enterprise content management solutions, being able to continue what we have been able to support our customers in providing information at the fingertips of our providers through what we call our universal patient window, which was described by Dr. Krieger, and being able to view all different types of content and to be able to access that content through our EMR and clinical device integration. Along with being able to access that at the desktop is being able to provide a mobile presence and being able to access that information from any location. So being able to leverage different devices, Android, iOS, whatever the device may be, to have an end user access that patient information, whether it be forms and consents in which the patient can complete the documentation electronically, as well as for the clinician and being able to view photos and documents related to patient care. Hyland Software is recognized by the American Hospital Association exclusively for enterprise content management solutions and consistently ranks in the top tier by KLAS. And most recently, Hyland Software was named a leader in Gartner's Magic Quadrant for enterprise content management. Thank you very much to, again, Dr. Krieger for the presentation today, and thank you, Anthony, for the opportunity to sponsor this webinar.
Well, thank you, Susan. Appreciate your sponsorship and the presentation. So now we have a good time for our Q&A. So as I mentioned, go ahead, send in your questions as they come to you, and we'll get them in front of Dr. Krieger. So Dr. Krieger, first question is, when it comes to paper, what should be the objective? Should an objective be to get rid of paper or to minimize paper? How do you go? How do you think about that? Do you see pockets of paper as being unable? You know, you shouldn't worry about getting rid of the few remaining bits of paper. Just tell me your thoughts around that.
Well, you know, I think we have to be realistic. You know, paper is part of the way the world works, and to try and set as a goal that we're going to be completely paperless is probably it's probably not going to happen. So I think we have to recognize that there's still going to be paper in our environment, but the question is, how do we archive that paper information and store it in a way so that it's safe, that it's retrievable, and that it's usable. But I think the reality is we're always going to have paper to some degree. So how do we adjust to that and try and minimize it, but recognize that it's not going to go away completely?
And is it sort of an incremental improvement process? So you have paper, and then the first step is to get those papers scanned into PDF form and get them into the record, and then perhaps to use some sort of natural language processing to extract some information out of those sort of laminated and static documents. What's a good way to think about moving up the scale?
Yeah, I think you're exactly right. You know, the first part of the process is how do you acquire the information. So once you acquire the information and it gets converted into some sort of image or document, now how do we use it more effectively? So how do we process it so that we can extract you know, some sort of structured information from it, and then how do we store it so that now we can go back and find it when we need it? And so I think you have to, you know, take each step sequentially and have a strategy for each. But I think part of developing that strategy for what you're going to do with a document is think about how are you going to use it, because I think that's going to inform the things that you want to know about the document and the way you're going to store it. So you have to have a sort of an idea of, you know, why am I acquiring this, where am I going to use it, and how, and what circumstances am I going to want to get back to it, and that's going to drive the rest of your work.
And what are your thoughts around sort of the hybrid world scenario where, and I've heard this is sort of not a good scenario, like a worst case scenario. You have things going on electronically, you have things going on in paper, and I guess the danger is there's no one source of the truth. Some things have been updated in one world but not in the other, and people don't know exactly what's going on. Can you see how that could happen? And is it very important to make sure that doesn't happen, and how do you make sure it doesn't happen?
Well, yeah, I mean, sure. You know, when you're living in a hybrid world, I think the big danger there is you have inconsistency of where you're looking for information. So, you know, the way, not so much the way around it, but the way to minimize that risk is to have standardized processes and standardized protocols about, you know, where you go for information and where you store the information. And I think if you can create that standardized process of managing information in the hybrid world, then you can try and minimize those risks. But as long as, you know, you have things coming in from all sides, there's always going to be a risk that you're going to, you know, look in the wrong direction for your answer. and so you just have to recognize that and take steps to try and minimize it.
Do you feel that the meaningful use measures have been helpful in hospitals getting their arms around the types of content we're talking about today?
Well, you know, the whole for meaningful use by itself really it demands interoperability. So in order to have interoperability, you know, you have to have structure, and enterprise contact management puts structure around unstructured data and allows it to be compatible within the EHR, and it allows us to integrate it, you know, integrate information from disparate systems. So I think in many ways, meaningful use has sort of provided the driving force for the innovation that was necessary to allow us to do this. Now, at the same time, you know, part of the problem is we become so focused on some of the regulatory requirements that we lose sight of what really makes the most operational sense. But I think meaningful use has really driven the need to create structure around unstructured information so that we can have the interoperability that it demands.
Now, we titled this event, Getting Your Arms Around Content Management. Do you feel that a lot of hospitals may be in a position like that where they've really just got to, things are kind of all over the place, and maybe some first steps you could suggest, or a way to approach the problem if it's kind of out of control?
Well, I think like anything, you have to try and break it down to, you know, what are the challenges and what are your goals. And, you know, whenever we do things at the clinic, we tend to approach things incrementally. So, you know, we'll create a pilot around a particular initiative, and then, you know, if that pilot is successful, or if it needs to be tuned, we'll make some changes, and then we'll gradually, you know, increase the scope of that work till eventually it becomes an enterprise effort. So I think, you know, like anything else, you know, it's a complicated problem, but you have to start somewhere. So you start with a small pilot, perhaps in a particular workflow or addressing a particular issue, and then try and improve the processes around that, learn from that, and then gradually expand it to other areas. But I think if you try and take it on all at once, then you're really sort of doomed to fail. I think it has to be done slowly, thoughtfully, and sort of consistently until you eventually, you know, reach your goal.
A question from the audience: how successful have you been with NLP, natural language processing?
Well, you know, I think natural language processing is it's interesting, and it has a lot of promise, but it's still proving itself. I don't think we have the answer yet about how to integrate it into our own daily practice. We're certainly trying out a number of different things with consumer software that's available. We also have some sort of experimental or projects that we're working on with IBM, with Watson, which really applies more advanced work around natural language processing to try and get information from data within the EHR, but I think it's still a work in progress.
Very good. You mentioned the fact that an EHR should not become some sort of general garbage dump for data. We've heard about the copy and paste problem, where you know, people are just dumping all kinds of information in. It becomes very user unfriendly for the clinician that is looking for some key pieces of data to wade through all that. Talk about how you're solving that at the Cleveland Clinic, and are there policies you have in place that say you cannot do certain kind of data dumps into the EHR?
Well, you know, I think when you start talking about copy and paste and things like that, you know, clinicians become their own worst enemy. And, you know, very often, you know, while we criticize those who do it, we often do it ourselves. But I think the only way you can do that, you can sort of get around that, is through proper education and through, you know, reinforcing best practices about how to document and about how to enter information into the EHR. And I think it's a learning process. We're still relatively young in our use of EHRs. The clinic is probably a little bit farther along. We've been on the Epic platform now for about 12 or 13 years, but many systems are really only adopting a lot of these platforms in the last few years, and we're still migrating from paper in many places. So it's very tempting to use that copy and paste function to get through the day. But I think as we develop better tools for documentation that are more intuitive and more efficient for the providers, then they're no longer going to feel the need to do this copy and paste to write their note or to get through the day. So I think we're in a bit of a transition that we have really suboptimal tools, and people are just trying to adapt to what's available to them. And as these tools get better, and as our use of the systems get better, that it's going to become less of a problem.
Very good. Question about what are some of the workflow challenges you've seen in content and image management, and how have you dealt with those? Anything come to mind there?
Well, yeah, I think the biggest problem, and really our strategy around enterprise image management, has been that we have so many different devices and places where images are acquired. And that image may be sitting on a thumb drive, or it may be sitting on a server under someone's desk, but it's not accessible to the enterprise. So we've sort of adopted this strategy of this enterprise image strategy, so that we still allow the user to acquire the images, and we don't control that process. But once that image is acquired, it's stored in a central repository that not only provides protection, because now we're able to back it up, but we're then able to distribute it across the enterprise. And again, that's been a very incremental thing. That wasn't something that was just all of a sudden turned on one day, but it was done sequentially for throughout our just different institutes and with different users, gradually bringing online different types of images. But it's not part of the normal workflow of, say, the gastroenterologist or the ophthalmologist to take these images and then sort of deliver them to the rest of the enterprise. So we have to figure out a way to acquire the image after it's been obtained, and then take care of that protection and that distribution, but still allow the end user who acquired the image to have access to the tools that they normally use to manage that image and to perhaps interpret that image. So I think that's a sort of a good example of how workflows can present challenges to the rest of the enterprise.
Very good. You mentioned, used into the word incrementally a couple of times, sort of describing the way Cleveland Clinic deals with issues and works to improve things. Cleveland Clinic is looked to as one of the standout organizations in the industry. Is there any more information or any more tips about the secret sauce that you've observed? I think you said you've been there a year and a half, that you've observed there that have stood out to you as something you would describe as the Cleveland Clinic way that others may want to emulate?
Well, I think that people always talk about innovation, and then my observations with people here is that there are a lot of people who really think out of the box, and they're very innovative in the way they approach problems, and they try to be inclusive of other groups or other individuals as they look for solutions to these problems. So I think that's one of the first things that I've noticed. The second thing is that the clinic in general, it takes a very thoughtful approach to the way that they care for the patients and the way they change their processes to enable that. And with regard to everything that we do, it's all focused around the same core principles, and one of those core principles is, and it sounds corny, but patients first. So everything we do is geared toward what's best for the patient. And as we change processes, if that's going to negatively impact our ability to deliver care for the patient, then number one, you have to think about whether or not you really ought to do that, or number two, how can we do it differently so that it mitigates the risk or minimizes the impact to the patient. And I think that's one of the reasons why we do so many of these projects incrementally, because we are such a large system that it takes time to refine processes so that they're appropriate for all users across the system. And sometimes you have to have various iterations. What may be right for main campus may not be right for one of our smaller regional hospitals. So you have to have that flexibility in design so that you accommodate all needs.
Very good. Next question. You've talked in the past about bringing end users into the process as a key in successful change management. How have you done that?
Well, I think technology is really a way to enable people to do their job. And when we look at a lot of the technology projects that we do at the clinic, 90% of the work has nothing to do with technology. 90% of the work has to do with defining the workflow and defining the process that needs to occur. And then the technology is just a way to operationalize it or enable it. So in order to design the technology properly, you have to have the end users as part of the workflow design so that you're actually accomplishing what it is that they need to accomplish. If you try and design technology without end user input, then you're creating something that may or may not actually address their needs. So the bulk of the work has nothing to do with the actual technology. It has to do with understanding the business and understanding the needs of the business, and then applying technology to facilitate that process.
Well, that is excellent, and I really appreciate it, Dr. Krieger. That's about all we have time for today. I want to thank you for joining us, giving the audience a lot of great information. Hopefully you will join us again for another event. I want to thank our sponsor, OnBase by Hyland, and Susan DeCaflino, who we've known for a long time, and we appreciate OnBase's support. As I mentioned, you'll receive an email when our archive recording is ready, usually within 2 business days, and separate registration is required. If you hold the CHIME CIO certification, you earned 1 credit today. Attending any of our events or webinars gets you 1 credit. And if you've asked us to let CHIME know, we will. If you haven't, don't forget to let CHIME know you've attended. Questions, comments, as always, email me. We're looking to keep this the best webinar program in the industry, so we're always looking for suggestions for improvements. And go to our website to view our upcoming program and see the last 12 months of archived events. So with that, I want to thank everyone again for joining us, and everybody have a wonderful day. Thank you.
All right. Thank you very much, Anthony.